What comes around goes around. Infectious diseases, common and unusual. Tonight, On Call with the Prairie Doc.
Starting this season, we are offering a Facebook Live option for our viewers to still be able to watch the show during the regular broadcast times on Thursday nights and ask questions. All you need is either your laptop, tablet, or a mobile device, such as your smartphone, to view the show. Here's how to do that. First, log into your Facebook account. If you don't have a Facebook account, go to facebook.com and complete the information to create an account. In the search bar, type in Prairie Doc. Make sure to click like on our Facebook page so you can get updates and notified when we are going live. Each Thursday on the Prairie Doc's page, you will be able to see a live broadcast of the newest episode. You can also ask Dr. Holm questions via Facebook Live. All you have to do is ask your question in the comment bar and await a response. If you miss a show live on Facebook, it will be available later both on the Prairie Doc Facebook site or at prairiedoc.org.
Good evening and welcome to On Call with the Prairie Doc. Dr. Holm is off for the evening. I'm Dr. Kelly Evans of the Avera Brookings Medical Group. Infection is the invasion of the body by a foreign organism. It may be bacteria, fungus, virus, or something more. Treatment depends upon the quick and correct identification of the attacker and the choice of appropriate response. First, let's take a look at this week's Prairie Doc quiz question. What is the name of the bacteria that usually invades the colon when antibiotics destroy our normal microbiome? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of Dr. Holm's essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your medical questions about infections as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is Dr. Archana Chatterjee, M.D., Ph.D., Chair of the Department of Pediatrics at the University of South Dakota Sanford School of Medicine. Welcome, Dr. Chatterjee.
Thank you, Dr. Evans.
All right, we're excited to have you, an infectious disease expert and educator of our medical students and trainees in our state. Timely topic tonight will be influenza, the flu vaccine. A lot of our viewers probably have been offered this at their pharmacies or physician's office. So why don't we just talk about maybe some of who should get the flu vaccine and what are maybe some of those common myths out there that we might be able to dispel for folks tonight.
Thank you. That's a very important topic. So influenza is not active in South Dakota yet. There have only been sporadic cases reported, so there's plenty of time for everyone, pretty much everyone, to get their influenza vaccine. This year we have more types of influenza vaccine available. There are vaccines that are more beneficial for older people. There are different formulations for children. So it's a good idea for everyone who's above 6 months of age. Under 6 months of age, we do not give this vaccine, but pretty much everyone over 6 months of age can receive the influenza vaccine. There are a very small group of people who might be highly allergic to that or might have had an allergic reaction that shouldn't get it. But other than that, pretty much everybody else can and should get the influenza vaccine. Now, when you talk about myths, there are a lot of them out there, unfortunately, about flu, the flu vaccine specifically. So one of the common ones we hear is that somebody who took the vaccine got influenza from the vaccine.
Yes, I hear that almost daily in my clinic.
And that is a medical impossibility. And we don't say much in medicine that's an impossibility, but in this case it is, because the influenza vaccine is not, the vaccines that are licensed in the US are not live vaccines. So they don't actually have live virus in them. There used to be one, and some people might remember that. It was the inhaled vaccine. That vaccine is no longer being used in the U.S. And so for the injectable vaccines, the shot, as people call it, nobody can get influenza from that vaccine. What might happen is that they might get the vaccine, and then a few days later, they either catch influenza or they could catch some other infection.
A common cold.
A common cold or some other virus. A lot of viruses co-circulate during this season, and they think they have the flu where they actually don't. And the reason that people who have had the vaccine still get influenza, because a lot of people say, well, I got the vaccine and I still got influenza. Well, what happens there is a couple of different things can happen. So one is that they got it late. And this happened to me actually in 2003. And I remember because that's the last time I had influenza. That year, for some reason, I was late in getting my influenza vaccine. I got it in November. And as luck would have it, that year influenza decided to come early. Usually influenza comes around December, January timeframe. That year it came in November. So about 3 days after I had got the vaccine, I got the flu. And it wasn't because the vaccine didn't work. Well, it didn't work because it didn't have enough time to work. So the vaccine takes a couple of weeks to help us produce antibodies, and that's what protects us from the influenza actually. So it's not instantaneously effective, you know, it takes some time to be effective. So that's one reason. The other reason is actually vaccine related, and that is that we know this vaccine is not the best vaccine we have. The influenza vaccine's effectiveness is at best around 70–75% when there is a good match with circulating viruses. So there's still some people who are going to get influenza even though they've actually had the vaccine and made antibodies to those viruses. The issue there is that those people will likely not get as sick and will likely not be sick for as long as they would have if they had not had the vaccine. And then the third thing with influenza is that these are viruses that change, particularly the influenza A viruses change from year to year. And sometimes it's a good match and sometimes it's not a good match. And in years that it's not a good match, the vaccine may only be 40–45% effective. So
that was true last year,
that's
correct?
Exactly correct. That's what happened last year. And so, you know, there are some truths about things that people are concerned about, but there are also a lot of myths around influenza vaccines.
Egg allergy, not a contraindication to getting the flu vaccine, is that correct?
Not any longer.
Yes.
It used to be that people who had severe egg allergies were told not to take the influenza vaccine. Most of your audience probably knows that influenza vaccine viruses are grown in eggs. That's one of the ways that we make influenza vaccines. There are other ways also, by the way, that we can make them now. And but a majority of them are still made in chicken eggs. And we realized a few years ago, actually, that people who had egg allergies really were not at increased risk for severe reactions from influenza vaccines. So they're still recommended.
Sure. And anything else that people need to worry about that's harmful in the vaccine? People talk about mercury and all these things that maybe have rolled over from decades past.
So most influenza vaccines, the single dose vials of vaccines, do not contain any form of thimerosal, which is a type of mercury product that was put into vaccines in the 1930s as a preservative. The multi-dose vials do still contain thimerosal, which is ethyl mercury, as a preservative. It's a very tiny quantity, and it's really never been shown to be a problem. But if anyone is worried about that, I would advise that they ask their medical provider to provide them with a vaccine that does not contain that preservative, and then they would be fine.
Okay, great. Now, we talk about flu being a good match year to year. What is it about influenza, the virus itself, that makes it so difficult to create a good vaccine when with other viruses we have vaccines that we don't have to change every year?
So this has to do particularly with the influenza A viruses. These are viruses that infect not only humans, but several different animal hosts. most commonly birds and pigs. And what can happen is that these different viruses can mutate. They can exchange parts of their genetic material, their RNA, so that they create some completely new viruses. And then we don't have vaccines, and the people who have been exposed to the old viruses don't have antibodies. So you have a population that is at increased risk. Now, the changes that happen year to year, these are what we call point mutations. They're small changes, but they're still different. And that's why each year people sometimes ask, well, why do I need to get the vaccine every year? That's why we have to get the vaccine every year. There are also big changes that happen where large segments of the RNA are changed. And that's when you get pandemics. And you might remember the H1n1 pandemic that happened in 2009. That's because that's a completely new virus. The entire world has no protection against it, and that can cause problems.
Yeah, good. And the other point is just that we don't know how virulent or harmful a virus is going to be that emerges every year. I recall when I was a resident, I believe it was 2013, 2014 year, an H1n1 virus emerged, and I was in the adult ICU in Denver, Colorado in January, and we had young, healthy adults on ventilators and some who died that year just because it was a particularly nasty virus. So the vaccine is safe in summary, recommended for everybody, protects you against a potentially deadly infection. I think we underestimate influenza at times.
I think it is extremely underestimated what influenza can do. And you know, I'm a pediatric infectious disease specialist, so I always talk more about pediatric cases. But right here in South Dakota, a couple of years ago, we actually had a child who died from influenza. It's a 2.5-year-old who died from influenza. So we don't think about deaths very commonly. Most of the influenza deaths happen in people who are 65 and older or who have underlying medical conditions.
Right.
But this poor child, unfortunately, was previously completely healthy and then ended up with the severe cases and ended up dying.
Yeah. All right. Get your flu shot, folks. All right, South Dakota has a good vaccination history. We seem to understand just how important it is to protect ourselves and our society from infections when we can.
The most remarkable vaccination success in the world is probably the eradication of smallpox. Smallpox used to ravage the population, all continents, all peoples. The vaccine was introduced 200 years ago or so, and in 1978 it was declared eradicated. Now, as we speak, in 2017, another dreaded disease, polio, is on the cusp of eradication. Back in 1952, over 60 years ago, we had over 1,000 cases of polio here in South Dakota. Thanks to vaccination, we haven't had a single case since 1963. So far this year, as of August 2017, we've only had 8 cases of polio in the world, 3 in Pakistan and 5 in Afghanistan. The places that have it, they are ruled or terrorized by the Taliban and certain sects like that kill vaccination workers. We have many other successes like measles. Measles used to, ravage the population. Every couple years we'd have a wave of measles come through. The measles vaccine was introduced in 1963 when it was licensed. Since then, measles has become very rare in South Dakota. We went 17 years without a single case here until around Christmas time, 2014. We had an outbreak in Mitchell. We had 14 cases associated with that, all in unvaccinated individuals. So that's who measles is hitting now. But we've got a highly vaccinated population in South Dakota, so we're at low risk. But the virus is still out there, and if you're not vaccinated, it may catch you. It's your responsibility. It's the responsibility of the parents, of the nurses, of the doctors, of the health department. Teenagers, I don't think have the awareness of disease or prevention yet. We do have some successes though. Our little kids, our kindergarten kids, and then overall, our influenza vaccination rates are highest in the country. We've been number one. We've had the highest immunization vaccination coverage rate in the whole country out of 5 out of the past 6 years.
This is your show, and your questions are key to our show discussion. Please call in your questions about infections to 1-888-376-6225 or send us an email to ask@prairiedoc.org. We have a couple questions, so we'll get started with those. A man from Sioux Falls asks if we could please explain the sources of sepsis and the chance of reoccurrence of sepsis. Comment there.
So sepsis is actually a clinical syndrome which describes the changes that take place in the body's physiology due to an infection, typically a bacterial infection, although there are some viral infections that can manifest with very similar symptoms and clinical findings that we see in sepsis. The source of these bacteria are often actually the individual's own flora. These are bacteria that we all carry around in our nose, in our GI tract. And sometimes what happens is that our immune system, which normally keeps these things in check and in control, is impacted in some way, whether somebody's undergoing cancer chemotherapy, for example, or radiation or something like that, or they have an underlying illness like diabetes, which has impacted their immune system. And in those situations, these bacteria can get loose, get into the bloodstream, get into places they're not supposed to be, and that can set off a cascade of events that leads to the clinical syndrome of sepsis. Usually that involves fevers, low blood pressure, breathing difficulties. There can be other manifestations that occur that make the person very ill. Recurrence of sepsis does happen, particularly if a person has an underlying disorder that puts them at risk. If they have an immune deficiency of some kind, some people have congenital immune deficiencies. We have children who have deficiencies of their complement system or their antibody system, something like that. Those people can definitely get recurrent episodes of sepsis.
Yeah. In most cases, though, if adequately recognized and treated, we think of most of these cases as resolvable. For, you know, the typical case that I see as an adult doc is a urine infection that turns into sepsis, for example. So this is a disease that has been heavily researched. It can be of high mortality if it's not treated. So we take sepsis seriously, and most of those patients are hospitalized and treated pretty aggressively.
It is a very serious infection, and many of those patients are actually in the ICU that you were describing before. Many of these cases actually secondary to influenza. So we see more cases of sepsis during respiratory viral season, during influenza season. And whether it's children or adults, this disease does have high mortality associated with it. So early recognition, early diagnosis and treatment certainly has an impact on reducing the morbidity and mortality from these infections.
Good. Okay, we've got more questions. A man from Sioux Falls asks, how common are infectious diseases after disasters like war and drought? Do these conditions enhance the effects of disease? And I guess something that we might think about is the hurricane in Puerto Rico and lacking of mechanisms to clean the water, et cetera. So can you comment on that?
Yeah, it's really interesting. You know, the Infectious Diseases Society of America actually had a conversation going on this topic and whether we had our conference in October, and whether we should have a session on these types of infections. It turns out that majority of the outbreaks that happen around disasters, whether they're man-made or natural, have to do with the disruption of normal civil services that we have. So water supply is a very important one, and so we think about waterborne diseases as causing outbreaks. Often there are outbreaks of cholera or salmonella or things like that can happen when people don't have clean water or access to clean water. There can be foodborne illnesses as well, because sometimes the food is not being able to be kept refrigerated as it should be, and it doesn't reach the people that need the food, and has already begun to spoil, actually. So foodborne illnesses can also occur. And then there are issues about things that people might be exposed to. For example, in the case of the floods in Texas, where all the stuff, for want of a better term, that might be in the flood water, while there are infectious agents that certainly could get in there, actually there's a lot of more concern about toxins and chemicals and things like that that might actually be in that water. So I would say, you know, it really is the disruption of normal services that causes most of the health issues that we see around disasters.
And complicated by the fact that those same disasters already also limit people's ability to seek appropriate medical care when they do get sick.
So that's an excellent point also, that we forget that the healthcare providers are impacted by these disasters just as the rest of the public is. I just came back from the American Association of Medical Colleges conference in Boston, and there was some discussion because the 4 Puerto Rican medical schools, we had people from there, and I talked to the dean from one of the medical schools actually, who said they were very severely impacted, and actually their medical students went out and tried to provide care and services, bring medications to people who were very badly affected by the storms there.
Interesting. Okay, next question. A woman from Alcester asks, how many times a day should I be washing my hands? And is it more important to wash my hands during these cold and flu season?
Excellent question. So simple things, hand washing or hand hygiene. So if you use those little dispensers that people have with alcohol containing sanitizer in them, that's great. And there are some times when it's very critical. So before preparing food, before eating, certainly after going to the bathroom would be a very important time to do that. If you have children or grandchildren, or you're taking care of kids and you're changing diapers or wiping their nose or whatever, it would be a very good time to do hand hygiene. Bottom line, you can't wash your hands enough. The more you do, the better it is.
Great. Okay, a man from Sioux Falls asks, what causes toe fungus and how is it cured?
Okay. So there are actually several different species of fungi that cause infections of the feet. Some people call it athlete's foot because a lot of athletes get this because they're wearing shoes and socks a lot of the time and their feet sweat. And that's a moist, warm environment for these fungi to grow. These fungi can actually affect your fingernails as well, which people don't think about as much. So, but toenail fungus is actually a pretty common thing to see. The cases we see in our clinics, the problem sometimes is that people have tried over-the-counter treatments, and if the toenail bed is actually infected, that will not respond to topical applications of creams or things like that. That actually needs a systemic antifungal, which means you have to take a medicine by mouth. The other thing we see with nail infections, nail bed infections, is that people don't take the medication long enough. So for a fingernail infection, it actually takes about 3 months to clear that up. And for a toenail infection, it takes about 6 months to clear up that infection. So you have to take the medicine for a long period of time.
And sometimes there are problems with that. In my practice of older adults who have a lot of other chronic illnesses, for example, the antifungal that we do use can have liver problems, and so that makes me not want to prescribe that to a lot of folks when the issue really is a cosmetic one when it comes down to it.
Right, and sometimes people will end up having that nail removed to try and help with the healing process, helping that process go faster. But these medications do have side effects, including drug interactions with other medications that somebody might be taking. So sometimes that is an issue, and that's where we say that maybe you want to call your friendly infectious disease doctor to get some help and get some options for your patients.
Great, great. Let's talk about another sort of hot topic in day-to-day medicine, and something that I think our viewers are becoming more aware of, which is what we would title antibiotic stewardship. But how our viewers might see this is, why didn't my doctor give me an antibiotic for my cough, for example? So can you just comment on the theory here, and that maybe the changing of the guard over the last 10 years or so?
So antibiotics have been life-saving medications. You know, they have really changed how we practice medicine and the impact that our work has. In the pre-antibiotic era, you know, a lot of people would die from simple infections that nowadays we think nothing of giving a few days of oral antibiotics,
right,
and they're fine. They are a double-edged sword, and that's the piece that we have begun to realize more and more. And thankfully, the public has actually begun to understand this as well. There used to be a time, I have a little cartoon that I sometimes show, of the poor doctor and, you know, the parents hanging on to the doctor's coat and saying, give us some antibiotics. And the doctor really doesn't want to do that, because we know that many of the symptoms, like a cough, for example, may be related to a viral infection, which doesn't respond to antibiotics. And that there is actually some harm we can do. In general, antibiotics are very safe medications. They have a very high, what we call a therapeutic index. So they're very safe medications to use. However, they do have adverse effects. And the common things are, you know, you might get a rash, or you might get an allergic reaction, or a diarrhea, or something. But there are much more serious adverse effects. You saw the quiz question at the beginning, which was a serious infection, actually, with a bacteria that can colonize the colon and cause serious damage, and sometimes life-threatening infection, actually, as a secondary effect of antibiotic use. The other thing that you mentioned earlier was about the microbiome. We are learning more and more about how the microbiome changes. So in case your viewers don't know what the microbiome is, these are the normal bacteria that we all carry around with us in our nose, in our mouth, in our GI tract, on our skin. And in general, these are the good bacteria. You know, they prevent the infectious bad bacteria from colonizing and causing infections. But when we give antibiotics, antibiotics are substances that they're indiscriminate. They kill all different kinds of bacteria, the good and the bad. And when the good are gone, that's an opportunity for the bad to come in and take up shop there and cause major problems. So there are a couple different reasons for us to say antibiotics are good, should be used for specific infections for specific durations of time. And really, the medical provider should be the one making those decisions. So for your audience, do not go and ask your provider for antibiotics. Tell them what symptoms you have. Let them figure out whether you need antibiotics or not.
Yeah, good. And what are us physicians thinking when we're evaluating a patient, for example, who comes in with a cough? How do we know which patients might have a bacterial versus a viral infection, and how can our patients be sure that we're doing the right thing?
Well, one of the common things is, how long has this been going on? You know, if they've had a cough for a couple of days, that is far less likely to be a serious bacterial infection like a pneumonia than a more common viral infection, cold virus, for example. It's also how sick they are. You know, I mentioned that viruses can make you very sick, but typically if you have someone who's really sick, has a high fever, is vomiting, has other symptoms, then you tend to think, well, maybe this is more serious than a common viral infection that they might have. It still may be a viral infection, but something more serious like influenza maybe. So it's the duration of illness, it's the severity. And then the third piece is we always think about the host. You know, is this a normal host? So I have a 5-year-old who's otherwise healthy, I don't have to worry so much about them. I have a 5-year-old who has cystic fibrosis, I have to worry a lot that that cough is something much more serious for that child with cystic fibrosis.
Yeah. So a lot of our initial thinking is essentially playing the odds. What are, you know, for cough for 2 days, the odds of it being a serious bacterial infection are quite low versus a different clinical presentation. And then, you know, we go to school and train for a long time, practicing, looking and listening to people and coming up with those decisions. So go see your doctor if you have a question, but hopefully you have a doctor that you know and trust and can trust their judgment.
Or at least call them if you're not feeling well.
Good.
Because you may not have to see them. Maybe they can tell you over the phone what you need to do.
Great. Okay. Considering how safe and effective vaccinations are, why would anyone opt out?
I think it's really concerning that we're seeing increases in childhood illnesses that we'd previously got rid of. Things like whooping cough and measles and mumps are all making a comeback. I investigated lots of outbreaks of whooping cough when I worked at the CDC, and often when I would present at medical conferences, older people who were retired would come up to me and say, I lost a sibling to whooping cough back in the 30s when we didn't have a vaccine that was readily available. And so there's a really different understanding of what these illnesses are like. I think nowadays, because we haven't grown up with them, we think, oh, it doesn't sound so bad. And actually, these illnesses can kill children.
And now for the winner of tonight's Prairie Doc quiz question. What is the name of the bacteria that usually invades the colon when antibiotics destroy our normal microbiome? The answer is Clostridium difficile, or more commonly called C. diff. Our winner was Jerry Brownschmidt, who answered that question correctly. Thank you, Jerry, for participating. And a book will be to you in the mail soon. All right, we've got another question here. A woman from Frederick asks, what causes a viral infection after cataract surgery, and how do you prevent it from coming back?
That's a question that I'm afraid I do not know the answer to.
Yeah, I don't think I do either.
What specific virus they're talking about.
Sure, sure. So it may be a better question directed right at your eye doctor.
Absolutely.
Okay, thanks. Well, we're still waiting for more questions from you. Please call or email us with those. We'll move on to maybe talk about some of those rare things that we sometimes think about and maybe are the more fun topics in infectious disease. So I think you had mentioned an animal transmitted infection that you have seen recently, or what we call zoonoses, infections that can go from animals to humans. Talk about some of the interesting cases you've seen, or things that might be particular for us to think about here in South Dakota.
So the most common one that we see in children is actually something called Tularemia. It's a bacterial infection. Very commonly it occurs in rabbits. Some people know it as rabbit fever, but it can actually occur in many different animals. And it gets transmitted often not directly from the mammal or the large animal, but actually by ticks, by tick bites. So it's very common for us to see these cases in the summertime. And often they will present with a lymph node enlargement or with fevers. There are rare cases of more serious infections like bacteria in the bloodstream, a sepsis-like illness, or a pneumonia, for example. So that's probably the most common zoonoses that we see here in South Dakota. But you asked about uncommon cases, and there are two that come to my mind. There's one that we are treating currently. It's a very recent case of a systemic cat scratch infection. So that's also a bacterial infection. We call it Bartonellosis. And this little boy had been having fevers for 4 weeks, was sent to us, actually was seen by my partner, Dr. Aureus. And we didn't know at the time what he had, but through his investigations, it was noted that he had multiple abscesses in his liver. And so this infection was suspected and was tested for and actually came back positive. So we started this patient on treatment with actually a cocktail of antibiotics, and he is slowly improving. So that's one case. The other case is actually from just about a year ago. I was on call over the Thanksgiving holiday, and I got a call to come in and see a child who had been walking. She's a toddler. She had been walking and had suddenly stopped walking. So she was initially brought in through the neurology service, And then they noticed when they did some initial blood work that she had an eosinophilia. So that's an increase in a certain type of blood cell. They're called eosinophils. And those happen very commonly with parasite infections. So
Which
then
are unusual here.
They're extremely unusual. So we got a call to come in and see her. And when I went in to see her, her mother said, "I don't think she can see." And so we did a quick examination, and it appeared that the child actually had gone blind. So we requested an emergency ophthalmology consultation. Long story short, it turns out that this child had a raccoon worm infection. It's called Bacillus ascaris.
Wow.
And the reason she got it is because she liked to eat dirt, and which is not uncommon in children that age. And she picked that infection up from the soil.
Wow. Interesting cases. We have a new Facebook question. What if a person is on a maintenance antibiotic for UTIs? This person specifies Bactrim, which is a brand name for an antibiotic. When they stop the antibiotic, their UTI seems to occur again. Should they stay on that Bactrim or try another medication? Or
So this is not an uncommon problem. Urinary tract infections are extremely common both in children and adults. And some people tend to have recurrent infections. Now usually they have some underlying problem because of which they're having the recurrent infection. So I would make sure that the individual is being tested. So in children we have what we call vesicoureteral reflux, where the urine, instead of flowing out in one direction, flows in the wrong direction. And that can cause recurrent infections. There are people who have diabetes, for example, who have recurrent urinary tract infections as well. So it's important to find out if there's an underlying cause and treat that in addition to treating the infections. With the preventative medicine, which we do use for some patients to try and suppress those infections from becoming more florid, we face two problems. So one is that you get breakthrough infections. And often when we get a breakthrough infection, that will be with a bacteria that is resistant to whatever you were using to prevent the infection from happening in the first place. The other is what we were talking about earlier with side effects, diarrhea, sometimes serious infections like the Clostridium difficile infection, things like that. So I would say that first of all, they need to see if there's an underlying problem, and if there isn't, then they need to talk to their physician to see if they need a different medication, if they're getting breakthrough infections, and if they are, when they stop and the infection comes back, then there's probably some underlying problem that hasn't been treated yet.
Okay, thank you. A man from Sioux Falls asks, why don't doctors perform more sensitivity testing on prescription drugs? I'm not completely certain about the intent of the question, but we can talk about sensitivities as it relates to antibiotics, for example. So tell us what the process is that a sample might go through in the laboratory that we take from someone's urine or blood to try and determine the source of infection.
So when we take a sample, whatever the sample might be, it gets sent to the lab. And we actually now have some new tests that are very rapid tests that we can run. These are called molecular tests, and sometimes they can tell us what the pathogen is very, very quickly, within a couple of hours.
Wow.
So, for example, we run respiratory panels pretty often, and there's a long list of bacteria and some viruses that's on there, and we find out what the person has within a couple of hours. At other times, especially when it's a bacterial infection, we actually need to grow these bacteria in the laboratory. So this is the old technology. You know, some people might remember those Petri plates that we used to grow them in. For blood cultures, we have blood culture bottles that we grow them in. But urine cultures, for example, are still done in the old way. You know, you streak them on a plate and you wait for it to grow for 24 hours. Once the bacteria grow, the technologists in the lab then take that bacteria and run a lot of different tests on it to identify it, first of all. A lot of these are biochemical tests, fingerprints, if you will, of the bacteria. And then they run what people call sensitivity tests. We have panels where you use discs that are impregnated with different antibiotics, and you place them on your Petri plate and you streak the plate. And if the bacteria are sensitive, you know, the antibiotic works, you'll see a nice clearing around the little the little disc, and you know that that antibiotic will probably work for that patient. So that's how we do sensitivity tests. Now, again, we have some newer technologies in the laboratory. This happened this past weekend. We have a patient, she's a little baby, a 2-week-old, that's got a Staphylococcus aureus infection. It's in her bloodstream. And I got a call on the weekend saying, well, she has a Staph aureus infection, and what should we do about her antibiotics? And so initially when she came in, she was quite sick. We gave her broad-spectrum antibiotics. But once we had that information, this is how physicians use this information, is I said, now we know it's sensitive to these antibiotics, so we can use a much narrower spectrum, more targeted antibiotic treatment.
Yeah, more targeted, try to diminish toxicity as much as we can once we have that specific information. Great. A man from Sioux Falls would like to know more about bronchiectasis and how that is treated, which is a complex question.
It is. Well, it's a complication. Usually occurs, it's much, much more frequent in adults than it is in children, although some children do get bronchiectasis. What that means is the bronchi are the airways. So when you breathe in, there's the upper airway with the pharynx and the larynx, and then there's the trachea, which most people know about, and then the trachea divides into 2 major bronchi, and then they go out into kind of this tree pattern. You know, if you see pictures of the lungs, sometimes you'll see this tree pattern. And then there's the alveoli, the air sacs, where the actual air exchange happens. So in some people, mostly due to either chronic or recurrent infection, you will see that these airways become sort of flabby. Sometimes you get these sac-like formations, you know, in the airway. The airway becomes weak, basically. The wall of the airway becomes weak. And what happens in that situation is that the secretions in the airway can pool in those areas, and bacteria love to grow in those areas, so they get more infections. So it becomes a vicious cycle, basically. In terms of treatment, we talk about good pulmonary toilet, you know, keeping the airway free as much as possible, and there's ways to do that. Certainly vaccinations, influenza vaccine is very important for anyone who has bronchiectasis. And then certain lifestyle things, like if they're a smoker, it's a very good idea for them to try and stop smoking. So those things will definitely help them. And then some people have such severe disease, they actually might need surgery to cut out parts of their lung that are very severely affected. So that's what I know about bronchiectasis, which is mostly an adult disease.
Yes, it is mostly an adult disease. And we see growth of resistant bacteria in these pockets just because it is such a ripe area for bacteria to grow. And these are folks that tend to be exposed to more antibiotics because they're having repetitive infections. A woman from Sioux Falls wonders if there are any advantages in using probiotics while you're on antibiotics to help restore balance in the digestive system. Also, she wonders if a plant-based diet might be more healthy that in a way that affects the microorganisms living in the gut.
Both excellent questions. So if I don't answer both of them, please remind me to answer the second question, but I'll address the first one first. Which is the issue of probiotics. And for people who don't know, these are the good bacteria. Right. And there are lots of different brand names, and there are lots of things that are available over the counter. Like most of these types of products, it's important to know what you're actually taking because there's a great deal of variation, and these products are not sort of reviewed by the FDA. They're not approved by the FDA, the Food and Drug Administration. So in the research studies that have been done, there are some things we know. So for example, people who have rotavirus diarrhea, if they take probiotics, actually it reduces the severity and duration of illness. So probiotics may be good in that situation. For people who are taking antibiotics, it actually might be helpful to take probiotics. We have a very severely ill child in the hospital right now with a severe case of complicated pneumonia. And this child was actually having some diarrhea, and I asked the primary team when they consulted us if we were giving a probiotic. So probiotics have been shown to reduce the risk of antibiotic-associated diarrhea and the duration and severity of that. So in some instances, probiotics are helpful. But a lot of people think, well, if it's good, then I should just keep taking it all the time, and that's probably not necessary.
Sure.
The other thing is that not all probiotics, as I said, are created the same. Some of them go in at one end and out the other. And there's actually, they don't attach, they don't have the correct molecular structure to attach to the gut lining. And so it's very important that people talk to their providers and make sure that they're taking the right product.
All right.
The question about the
I'm actually going to cut you off. We have very little time left. We have 3 questions. We're going to try and rapid fire and see if we get people their answers, okay?
All right.
All right. Thanks for all the questions tonight. A woman from Delmont says, I have bad cases of bladder infections, but the doctors hesitate to put me on antibiotics because I've also had C. diff. They want me to self-catheterize, but I'm not able to do that. Where do I go from here?
I would say that they should probably talk to their doctor about getting a second opinion, maybe. There are some things that people can do. So there are some, we were talking about plant-based products that might actually be good. And so cranberries actually have been shown to reduce the risk of certain types of bladder infections. So that may be beneficial. Some people drink cranberry juice or take those tablets. It's not a cure-all by any means, but it might be helpful.
Yeah, it sounds like she's
but
in a complex situation.
This is a major problem, and she probably needs to get a second opinion.
Okay, a man from Clear Lake had shoulder surgery in June. They found kidney cancer, and then he developed an infection. After that, he had another shoulder surgery. He was taking an IV antibiotic, ceftriaxone or Rocephin, and he developed a seizure. Is there a correlation to having the seizure with the antibiotic? After he had a seizure, they put him on levofloxacin, and then he had Achilles tendons problems. What is our opinion? You had a terrible luck, man from Clear Lake.
This is not an uncommon type of story, though, that we hear where one problem leads to another to another. So ceftriaxone association with seizures is not common. There's a different class of antibiotics, carbapenems, that have been shown to be associated with seizures. So I would say probably not, but you can never say never. It's a possibility, certainly, which is why they changed his antibiotic.
And the levofloxacin with Achilles tendon issues, that is a well-known thing. It's uncommon. All right. Thank you so much for your questions. We couldn't even get to all of them, but we appreciate them. We'll be right back after this.
Because they want you to be there for the many milestones yet to come. Because you don't want to miss out on the little things. There are many reasons to get life-saving cancer screenings. 1 in 8 women will be diagnosed with breast cancer in her lifetime. But regular self-exams and mammograms can catch it early when it's most treatable.
Promise?
Promise. 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 Promise.
Make the promise to get screened. Do it for the people you love. For more information about life-saving screenings or available financial assistance, visit getscreenedsd.org.
In 1966, a 10-year-old boy from Hamlin County, South Dakota, was sleeping out with his buddies when a skunk crawled into his sleeping bag and bit the boy in many places, including the face. Despite providing the child with the old-style vaccinations, the boy succumbed to rabies within a month. There's been only one more human case of rabies in South Dakota since, and that was also a young boy attacked by a skunk. Even with present-day technology, once rabies gets into the nerves, it is at least 96% fatal in humans. Rabies is believed to kill more than 55,000 people every year in Africa and Asia alone, most of them after a bite from a rabid dog. By comparison, in the U.S., rabies kills only about 2 or 3 people per year. Over the last 50 years in the U.S., we're down to that low number of annual deaths due to an effective vaccination program for domestic dogs and cats, along with improved rabies post-exposure prevention, or rabies PEP treatment. Domestic animal vaccination has been successful in containing rabies, but not in wild animals. The newest PEP is so protective because it includes 1 injection of antibodies targeted specifically against rabies, along with a series of 4 vaccinations. Human cases of rabies in the United States are rare, but we still have plenty of animal rabies. In South Dakota, over the last 10 years, we've tested 6,500 animals suspected of having rabies and found 5% tested positive. Specifically, 195 skunks, 48 bats, 47 cows, 22 cats, 16 dogs, 8 horses, 3 goats, and 2 raccoons were rabid. Please take note that none of the 16 dogs infected had been vaccinated, giving credibility to the value of vaccination. Of all the bats tested, only 3% were positive, while 48% of the skunks tested were rabid. This gives another reason, besides bad odor, to avoid skunks. Just last week, a Sioux Falls man was walking his dog late in the evening near many evergreens when something was crawling on his forearm, causing him to brush off whatever it was. When he got home to the light, he noted tiny double bite marks on the forearm, which were highly suspicious for bat bites. Since South Dakota bats are usually bug eaters and not arm chewers, this incident was worrisome. The doctor recommended rabies PEP for him. Bottom line, vaccinate your pets. Avoid messing with wild animals, and seek immediate medical care whenever bitten by any animal.
There are many myths about the flu vaccine, but they really don't stand up to the true science-based data.
Now is the time to get your flu shot. In fact, the virus is already circulating in South Dakota. We've had 1 person hospitalized, that's been reported, and we've had several cases, but it's at a level that we call sporadic, which means just a case here or there. But that dirty virus, it's going to make an outbreak again this year. Yeah. And with flu, we never really know, which strain is going to be predominant, although we have a hint already this year, and we never know when exactly it's going to peak. Sometimes it peaks around New Year's, and sometimes more typically in February or March. There's always a few sporadic cases in October, and then typically in November it starts picking up, and then sometimes it hits with a bang and just crashes down on us, and we have about a 1-month outbreak, and then it's gone, and some years it just drags on and on and on, making people sick, putting people in the hospital, and killing people. Last year, 44 South Dakotans died from influenza, and nearly 1,000 were hospitalized. And that's preventable, or at least amenable. Last year, South Dakota had the 2nd highest influenza vaccination rate in the whole country. We were over 50%, and we'd like to see 90% so we could protect the whole community. Herd immunity is especially important for people that can't get it, especially little babies, because you can't even get the shot until you're 6 months of age. So mom, dad, brothers and sisters, daycare, anybody coming around that baby should have the flu shot so the little infant will not get sick. And people who are compromised in any way, they should also have everybody around them with the flu shot. There are many kinds of flu shots out there. There's now kinds without any egg components, so people that formerly had egg allergies to the flu shot, they can get it. There's a souped up dose. That's the double dose, and that's for the elderly, 65 years and older. Some people get that. There's really no excuse not to get the flu shot anymore. There's a wide variety, so check with your doctor, check with them, and get what's best for you. If they give the shot in your arm may get a little red and a little sore for a day, and that's the extent of it. Any of us could get sick from anything on one particular day. It's just pure coincidence if you get the flu shot and the next day you get diarrhea or something like that. By and large, people do not get sick at all from the flu shot. That's urban myth, it's old wives' tale, and it's not true. So just get your flu shot. It will protect you from the flu, or at least from being hospitalized and probably even killing you.
A big thank you to our guest, Dr. Archie Chatterjee. Her experience and insight into infectious disease added greatly to tonight's discussion. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people, and get your vaccines.
That's great.
truly is your show, as you may ask anything medical, and we'll do our best to answer your questions. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions: Brookings Health System, Ophthalmology Limited, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen District Medical Society, Black Hills Medical Society, 3rd District Medical Society, Brookings, Madison and Flandreau, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications.